Mr. Martinoli, welcome to our Congress. We want to take you again for your presentation. My name is Dr. Gökhan Polat. I'm working in Istanbul Medical Faculty with the Hemofili team. I want to introduce you to our Turkish audience first. Doktor Carlo Martinoli bir radyolog. Kendisi özellikle Kas İskelet Sistemi Radyolojisi'nde çok sayıda literatüre yayın kazandırmış, kitapları referans olarak sunulan bir kişi. Bize değerli bir sunum yapacak. Mr. Martinoli, you can begin your presentation. Thank you very much for your presentation again. You can start.
Okay. Thank you very much for your kind introduction. And today is a long job because we have 1 hour and a half to speak about the technique, the scanning technique used with ultrasound to examine the 3 joints of interest in hemophilic arthropathy. Then we'll describe the general pathological findings we can encounter at the joint level with ultrasound in this disorder. And finally, if we have still time, and we'll describe the scoring scale, so how to score the abnormalities detected at the joint levels in terms of disease activity and osteochondral damage. So I'm very happy to be here and to have this opportunity to speak about this system as a point-of-care system. And the aim of the EDAS protocol is to provide a flexible tool for clinicians to be integrated with physical examination, and when the main aim of the system is to increase the sensitivity of physical examination in identify the early changes related to the disease process. So we start with the elbow, and the EDAS scanning protocol starts on the anterior aspect of the joint, as you can see here. The joint is extended on the examination table, and then the transducer is placed on the anterior aspect of the joint, just proximal to the joint line, and the probe identify here the main landmarks represented by the humeral shaft and the brachial artery, and then we go down and we stop in this area when the profile of bone becomes biconcave. This is the area where we have the 2 fossae in the level of the anterior aspect of the distal humeral epiphysis. The radial fossa is located laterally, the coronoid fossa is deeper and located medially. And these bony landmarks are important because we can use them to recognize the recesses. And we can see here the radial recess and the coronoid recess. So the 2 recesses are located underneath the anterior fat pad visible here. So note that the fat pad is brighter, is more echogenic. And then remember that this is the level of the joint capsule, and superficial to the joint capsule, we see a big muscle, the brachialis. So after examining this area to identify if recesses are distended by synovium or effusion, we go down, slightly down, not much, just 1-2 centimeters down, and we stop again until we stop over this image. No, this is a wavy, the wavy appearance of the distal humeral epiphysis, and here you see the capitellum. The capitellum is convex, and the trochlea on the medial side characterized by two facets. One is the lateral and the other one is the medial facet. Note that bone is very smooth, very regular, and the articular cartilage is relatively uniform across the surface. The cartilage is the black band you can see here, superficial to the cartilage in normal states. When there is no distension of the joint space, we see the echogenic appearance of the anterior fat pad. After that, we change our scanning plane, as you can see in the animation, and after examining the joint surface, changing orientation of the probe to make the probe exactly perpendicular to the subchondral bone to have a good delineation of the cartilage, we place the probe longitudinally at the level of the radiocapitellar joint. And this is the corresponding image from cranial to caudal. You can see here the level of the radial recess, and you can see the position of the recess is very close to the bony floor. Then you see the anterior fat pad, much more echogenic here, and superficial to the anterior fat pad, this is the muscle, is the brachialis muscle. Note the capitellum in using the sagittal planes. The capitellum is perfectly round and is covered by a regular band of articular cartilage. This is the level of the joint space, and the distal to the joint space, we see the radial head. It has a squared appearance. It is covered with some cartilage, as you can see here. And more distally, you see the concavity of the radial neck, and this is the position of the annular recess. So using this scanning plane, we check the same structures already evaluated on transverse planes. And so we give a look to the radial recess first, and then to the capitellum to identify if the osteochondral surfaces are regular. After that, after placing the probe over the radiocapitellar joint, I move the probe from lateral to medial, as you can see here, just to screen the surface and to identify any possible osteochondral damage. And so the image will change, the radial head will disappear going towards medial, and we see another bone appearing in the field of view of the ultrasound image, the coronoid process of the ulna. So this is cranial, this is the caudal side of the image, and you see here the position of the coronoid recess located close to the floor, to the bony floor here. You can also have a nice depiction here of the anterior fat pad that looks more echogenic. The anterior fat pad is indicated by an asterisk, and more superficially, you can see the brachialis going to insert at the base of the coronoid process. This is the trochlea, so the placing the probe medially on the anterior aspect of the elbow joint, the capitellum disappears, and you see the trochlea, the two facets of the trochlea covered with cartilage. So this is the joint line, and this is the trochlea-ulna joint. So after that, we go back and forth to understand that everything is well analyzed on the anterior aspect of the joint, and we perform the last scanning plane. The last scanning plane is to evaluate the last recess of the elbow, the olecranon recess. And to do that, we have to invite the patient to flex the elbow at 90 degree, at a 90 degree angle. Remember, 90 degree is very important to identify the bony landmarks in their correct position. The probe is aligned to the long axis of the forearm, as you can see here, and you see an image like this one. So the bony landmarks include the olecranon that is located distally, the trochlea covered with some cartilage. So this is the posterior aspect of the trochlea. The anterior aspect was examined using an anterior approach. And after that, you see the fossa. This is the olecranon fossa. So the position of the joint line is this one. And then when we have some effusion or synovium, the effusion and synovium migrates here. So the synovium may be found superficial to the articular cartilage investing the trochlea. And then the distinction, the recess is located in the deepest part of the fossa. So when we have synovitis, this is the arrangement of the synovium. The synovium migrates down to fill the recess that is located close to the floor of the olecranon fossa. The rest, the big tissue you see here is related to the posterior fat pad and indicated by an asterisk. Superficial to the posterior fat pad, this is the level of the articular capsule, and more superficially you see the triceps. This is the myotendinous junction of the triceps, and this is the tendon going to insert into the olecranon in a more distal position. So that's it. These are the scanning plane to image the elbow. Remember to be very systematic. We start with transverse planes anteriorly to check the anterior recesses and the osteochondral surface, investing the anterior aspect of the distal humeral epiphysis. Then we move the probe longitudinal in a sagittal plane to check the same structure with a different perspective. And finally, we move posteriorly to analyze the last of the elbow recesses, so the olecranon recess. So I think you can do is also to speed up the process is to invite the patient to cross the forearms, the so-called classmate position. And so when you end the examination on one side, you check the posterior side of the other elbow, and then you complete the examination of the other elbow with the anterior scanning planes. So using this kind of position, the probe placement is easier, and you can save some minutes during the examination. Remember that the ideal to have a good examination of the osteochondral surface is to extend the elbow. In some instances, we don't have any need. The patient is able to extend the elbow completely on the table, especially if the examination table is high. But if you see that the elbow is not enough extended, you can invite the patient to place a fist on the back of the elbow joint. And then you are here with the probe and you compress the elbow from an anterior approach. So you squeeze the soft tissues, and this may make the osteochondral surface more superficial and amenable to ultrasound examination. So especially when the elbow is thick, or in overweight patients, this maneuver is very important. So you have to press over the elbow, and placing a fist on the back may help a lot, and the quality of the ultrasound image improves significantly using this kind of technique. The second point to remember is that the surface of the osteochondral of the cartilage and the subchondral bone is wavy at the level of the distal humeral epiphysis. So it's very important to change to the orientation of the beam, so to rock the probe over the surfaces to make them exactly perpendicular to the beam. So with some pressure and rocking the probe continuously over the osteochondral surfaces, we have a better delineation of the cartilage. And so you can increase your confidence about the possible presence of a damage. It's an important maneuver to perform in order to distinguish what is an artifact from an actual pathological finding. Okay, so another important point when you scan the elbow is that in many cases the fat contained in the anterior or in the posterior fat pads may look hypoechoic like synovium. So, and it may be tricky to understand if the hypoechoic image you see is related to synovium or is related to a hypoechoic darker fat lobule. Look at this image, and in this image you see a hypoechoic area here in the posterior fat pad. Then you see another one here, and finally a third one. So remember the rules to distinguish synovium from fat include continuity of the area with the joint space. And in this case, they are number one and number two are isolated isles of hypoechoic fat, not connected with the joint space. Number three is connected with the joint space. And so this is the first point. The second point to be considered is that number three illustrates, it's located in the appropriate position of the recess. So where is the recess? This is the position of the recess on the posterior aspect of the elbow joint. So not this point, and never here in a so superficial position embedded in the posterior fat pad. So these are important criteria. The third criterion is the fact that the synovium is collected in a pouch. So it's very well delimited. And on the other hand, the hypoechoic fat may present with strands. It may have a bizarre appearance. And so this may also help to distinguish the fat from synovium. Remember the connection of the recess with the joint space. This is very important because it is a key feature to avoid confusion between hypoechoic fat and synovium. So you see here an image like the pissing baby here. This is a statue in Brussels. Moving to the knee, the technique to scan the knee involves the systematic evaluation of the recesses, and in order to save time, we decided to exclude the posteromedial recess. Of course, our patients with hemophilic arthropathy, they don't have a Baker cyst, so there is no need to go posteriorly to check the posterior areas of the joint. And so the scanning technique included this systematic evaluation of the suprapatellar and parapatellar recesses, plus the evaluation of the osteochondral surface of the femoral trochlea. The femoral trochlea is well exposed, is very wide, and it can give us a clear idea of the presence of an osteochondral problem. So we start with the knee flexed at approximately 30 degrees. Then the probe needs to be firmly stabilized by your hand in the suprapatellar area we start with the sagittal plane, as you can see here, and this is the respective image showing the upper pole of the patella. Remember to include the patella anytime in the field of view of the ultrasound image. This is the femur, and then remember the quadriceps tendon is a multi-layered tendon going to insert at the level of the upper third of the patella. On the undersurface of the quadricep, we have two fat pads. Again, the prepatellar and the prefemoral fat pad, and the suprapatellar fat pad is located in between these fat pads. So the suprapatellar recess is located here. So this is the first part of the recess. Then the recess extends more cranially, and it passes between the quadriceps and the prepatellar fat pad. After that, we change the position of the probe. We go on the sides of the patella to check the medial and the lateral parapatellar spaces. They are the most dependent part of the suprapatellar recess. And placing the probe on the sides of the patella, we see the lateral or medial edge of the patella on one side of the probe, and then we see the medial or lateral femoral condyle. This is the lateral or medial surface of the respective condyle. The parapatellar recesses are located just superficial to the flat bony surface of the condyle. Superficial to the recesses, we have the patellofemoral retinacula, but we don't have to take care about these structures. After that, after examining the suprapatellar and the parapatellar recesses, we place the probe in a coronal plane. The probe has to be oriented in the long axis of the leg. And so in this image, we see the medial femorotibial joint space. You see the interruption in the bone continuity here. This is the profile of the medial meniscus. In some instances, you can see the medial collateral ligament bridging over the meniscus and passing from this area down to the tibia. Remember that the shape of the femurs ends here and is a bit curvilinear. The tibia is very straight and sharp in this location, and we use this scanning plane to identify any osteophytes. Remember that in case of osteophytes, they are growing up and on the sides of the medial meniscus, and until you see that the bony surfaces are flat, are not moving up with some bony outgrowths, this means that there are no osteophytes. Then when you have osteophytes, you can also see the extrusion of the meniscus, and you can also realize that there is a reduced joint space in this area. After that, after examining the medial side of the joint that is commonly affected in this patient, we invite the patient to dorsiflex, to hyperflex the knee joint, and we place the probe over the knee joint in a transverse plane just to examine the osteochondral surface of the femoral trochlea. And this is the appearance of the femoral trochlea on ultrasound. You see the two facets of the trochlea, you see the subchondral bone here, and the cartilage is very thick. So there is a thick slab of cartilage covering the subchondral bone in this area. So these are a couple of images to show the extension of the suprapatellar recess and the relationship of this recess with the parapatellar ones. So remember that in between the two fat pads, we have the first horizontal part of the recess. It lies between the suprapatellar and the prefemoral fat pads. And until I see some effusion or synovium in this area, the finding is normal. But to have an abnormal finding, the effusion or synovium should extend more proximally, just to open the space between the quadriceps tendon and the prepatellar fat pad. In this case, more pressure is needed to create this kind of opening of the recess. And so the involvement of the vertical part can be considered pathological. So this is a very simple rule, but it works very, very well. After that, you can see the continuity of the suprapatellar recess with the parapatellar ones. This is the appearance of the parapatellar recess. You can recognize here the flat appearance of the lateral femoral condyle. As we described it before, bone is really flat in these areas. So this is an anatomical picture showing the lateral and the medial facet. And if you give a look to this image, this is a cadaveric image obtained in full flexion of the knee joint. You can see that using this position, the patella migrates down. This is the quadriceps tendon, the whitish tissue you see here, and you can expose the trochlear cartilage for an appropriate examination. So there is no bony structure located superficial to the trochlear cartilage, but this surface is curved. And so you have to change the orientation of the probe to make the ultrasound beam quite perpendicular to the surface. This is very important because the overlying tendon, the quadriceps tendons, may appear artifactually hypoechoic if the beam is not exactly perpendicular to it. And this may create difficulties to separate the tendon from the underlying cartilage. In some instances, the width of the osteochondral surface of the femoral trochlea may be wider than the width of the probe. And so when you scan this surface, one trick of the trade could be to start on one side, to move the probe towards the top, and then to go back on the other side of the trochlea. This is to avoid to crop the most external or internal parts of the cartilage. So when another important point to remember is that on the medial aspect of the femoral trochlea, the cartilage may continue even beyond the end of the medial facet of the trochlea. And so you can see an image like this one. But after you cross this bony angle medially, the cartilage here shouldn't be evaluated, and it shouldn't be considered a loss in thickness of the cartilage. When we see this kind of image, is normal, because we have to stop our evaluation at the level of this angle. Remember, this is commonly observed medially. And when you see the cartilage as it tapers gradually and ending here to continue with the periosteum, this is absolutely normal and it should be disregarded. So, because we are external to the osteochondral surface. In some instances, on the border of the trochlea, of the trochlear facets, we are able to demonstrate some osteophytes. Now, this is a very common finding. We discussed the hypoechoic appearance of fat at the level of the fat pads in the elbows, but fat may also appear hypoechoic in the knee. And so you know that the recess is located between the suprapatellar fat pad and the prepatellar fat pad. So if you have difficulties to understand if an hypoechoic image belongs to the recess or not, so you see this kind of image, for instance, no? And you don't know if this is a synovium distending the recess. So if the recess extend from this point to that point, or if the recess is just this darker line in between hypoechoic fat, you should perform this kind of maneuver. You should invite the patient to dorsiflect and plantar flex the foot, or you can catch the cuff and you can invite the patient to dorsiflex and plantar flex. When you perform this kind of maneuver, this is what happens. So you see the two fat pads as they glide with each other. And so during dynamic scanning, everything becomes very clear, and you understand that these structures are not related to some content of the recess, but they reflect the typical appearance of the fat pads. So remember this point. Moving to the ankle, remember that in the ankle we have to check two joints, and these joints are the tibiotalar and the subtalar. So we start here at the level of the anterior recess of the tibiotalar joint by placing the probe in the long axis. This is the best position for the patient. We have to invite the patient to point the heel on the examination table. And so with the ulnar side of our hand, the hand holding the probe, we can press over the forefoot to open the space and to disclose some surface, some osteochondral surface from the cover of the tibia. This is what we do by placing the probe over the anterior aspect of the joint. And one of the most important bony landmarks here is represented by the talus. And the talus, when you place the probe not exactly in the midline axis, but when you move the probe slightly lateral, is made of three parts. We have a cranial part, is the dome, the most anterior part of the talar dome covered with some cartilage, and this part is convex. Then we have a concave part, the neck of talus, and the neck is not invested with cartilage. And finally, we have the prominent head just here. So three parts of the talus: dome, neck, and head. And remember, the only one covered with cartilage is the one of the dome. Then this is the normal appearance of the distal tibia. The tibia has a downsloping contour here. And this is the level of the joint space. Similar to the other joints, we have fat pads in the ankle as well. And this is the anterior fat pad. So the joint capsule is located here. It bridges over the fossa created by by the bony floor. And superficially, we see other structure, including the dorsal pedis artery and the extensor hallucis longus muscle. So after examining the anterior recess, we have to go right and left with the probe, but the probe is placed on the transverse plane. And this scanning plane is very important to identify the osteochondral surface of reference. And when, the dome is curved, but when we place the probe transversely, this is the appearance of the talar dome. It's very flat, and you are able to demonstrate a thin layer of cartilage. And the cartilage is continuum, forms a continuum there, so it shouldn't be interrupted. So you have to go up and down, and going up, you have to tilt the probe a bit, as you can see in the image, because the surface is curved. After that, we change the patient position. We place the probe in inversion, and then we place the foot in inversion, and we place the probe on a transverse plane at the level of the sinus tarsi. So the probe should be parallel to the examination bed, and we are able to demonstrate a very deep groove in this area filled with heterogeneous fat. In this area, we have two recesses, the recess of the subtalar joint and the recess of the talocalcaneonavicular joint. And we have to consider these recesses as an expression of the subtalar joint. So we have to check this area to identify some effusion or some synovium. Finally, after this scanning plane, we have to rotate the foot externally, and then we have to dorsiflex the foot. We have to place the probe vertically on the back of the medial malleolus. The probe needs to be in close contact with the malleolus. It should scrape the malleolus, and then the shaft of the probe should be placed halfway between sagittal and coronal. And in this case, we are able to demonstrate the last two recesses of the ankle joint, the posterior recess of the tibiotalar, and then going down the posterior recess of the subtalar. Of course, the bones, the profile of bones may help us to identify which recess we are scanning at the moment. So remember that the posterior recess of the tibiotalar joint is characterized by a cartilage layer investing the most posterior part of the talar dome. So when we see some cartilage here, this cartilage belongs to the talus, and the joint space here is related to the tibiotalar. At the level of the subtalar, we don't have any kind of cartilage. So remember that the appearance of the sinus tarsi is very heterogeneous, and you should be careful not to make confusion when you see a hypoechoic image located within this space, within the groove. And the heterogeneous nature of fat here is related to the fact that the space is crossed by retinacula, by ligaments. There are a lot of structure causing some attenuation of the ultrasound beam. From the anatomical point of view, it's important to realize that if this is the tibiotalar joint, and so we commented about the anterior recess of the joint here, and this is the posterior recess of the tibiotalar, the subtalar joint is more complex from the anatomical point of view because it includes a proper subtalar, visible here in red. There was some injection of red latex in the proper subtalar joint. And then we have another joint more anteriorly, and this joint is the talocalcaneonavicular joint, or the Chopard joint. It's a completely separated, is another joint, is separated from the subtalar one. So, but when we see some effusion or synovium in this area, we don't make a difference between tibiotalar, between subtalar and the talocalcaneonavicular joint. For us, it's important to understand if the recesses are empty or if the space is filled with effusion or synovium. So this is a radiographical examination. You see the area of the tibiotalar joint here. This is the subtalar joint. You can recognize the subtentaculum tali, and these are the two bony walls of the sinus tarsi. So you see a radiolucent area in between the two borders of the sinus. So so this is the arrangement of the two joints. and they don't communicate with each other in the middle. Remember, another very important point to remember is that the position of the recesses of the two joints are located inferiorly here. So when you place the probe at the level of the tibio-talar joint and you are too dorsal, the sinus tarsi may appear completely empty, so no process, no pathological process visible there. But when you go inferiorly, something may appear. So it's important to drive the probe inferiorly. This is really relevant when you scan this area. If not, you can miss some distension of the recesses by synovium or effusion. So, and there is a way, there is a trick of the trade to understand if synovium belongs to the proper subtalar joint or to the talocalcaneonavicular. In case the synovial pouch is close to the lateral process of the talus, this is so to the posterior wall of the sinus tarsi. This means that it belongs to the subtalar joint. If we see that the synovium is in close proximity with the anterior wall of the sinus tarsi, it belongs to the talocalcaneonavicular joint. So based on the location, we are able to distinguish the recesses of the subtalar and the talocalcaneonavicular from each other. But this is just an anatomical observation, because we don't need to make an anatomical difference. We have just to check if there is synovial distension of these recesses in the area, regardless if they belong to one or the other joint. So moving to the last scanning plane, this scanning plane is believed to be not really easy to perform. Remember that we have to follow a strict rule to do some specific things to obtain a nice image on the screen, illustrating the status of the posterior recess of the tibio-talar and the subtalar joint. So it's something like a shopping list, no? When you go to the market, you have a list of things to buy, no? So the first point is to place the probe vertically. So, and this has to be done first. Then we have to invite the patient to dorsiflect the foot. The probe needs to be in close contact with the medial malleolus, and remember, tilted 45 degrees, half away between coronal and sagittal planes. If you don't do any of these things, at the end, you are not able to reproduce these images in the screen. So this is the posterior recess of the tibio-talar, posterior recess of the subtalar joint. When you check the surface, the osteochondral surface of the talar dome, remember that the transition between cartilage invested surface of the dome from the neck, and the neck is bare bone, is not really linear. So the transition is wavy. And so when we place the probe here, this is what happens. You see the cartilage, this is perfect. You see the subchondral bone, again, perfect there. And then when I go more distally, I see that the cartilage disappears in this area, but not in the other one. And this may be misleading, because I can interpret this lack of cartilage as a problem, as a damage related to the osteochondral surface. And this is not true. It's just because you are scanning the level of the area of the transition between dome and neck, and the transition is not exactly linear. So be careful, look at the probe position on the skin, and so you can understand if the defect in the cartilage is real or it depends on the on anatomy. So remember that cartilage damage typically occurs cranially, closer to the white bearing area, not at the level of the transition of the cartilage with the neck. Similarly, when you scan the posterior ankle, remember that both the posterior recess of the tibiotalar and the posterior recess of the subtalar joints have a close relationship with the flexor hallucis longus tendon. And the flexor hallucis longus tendon can be easily identified dynamically by flexing and extending the greater toe. In some instances, there is a communication of the joint space with the sheath of the flexor hallucis longus. So in cases of huge effusion at the level of the ankle joint, remember that the effusion may pass within the sheath of the flexor hallucis longus. And so this should be examined. Is not part of the EDAS protocol, but of course, if you give a look to the flexor hallucis longus, you can also disclose unexpected effusion within its sheath. Then remember that when you place the probe at the level of the posterior ankle and you see the posterior aspect of the tibiotalar joint, this is the posterior aspect of the subtalar joint, the tendon curves here and it becomes hypoechoic. So it may be confused for some synovium exiting the joint space and then forming a structure like a mushroom there. So it's important to tilt the probe. And when you tilt the probe, you understand that the hypoechoic image visible here is related to anisotropy. So it's related to the tendon and not to synovium emerging from the subtalar joint. So this was an overview of the scanning technique, and I described the technique, the EDAS technique to scan the three joints of interest in hemophilic arthropathy, the elbow, the knee, and the ankle. Of course, the scanning protocol is very standardized. You should perform this examination using the scanning planes I described, nothing more. And the main goal is to have information about the status of the joint recesses and the status of one osteochondral surface per joint. And this osteochondral surface is the distal humeral epiphysis for the elbow, the trochlea for the knee, and the talar dome for the ankle. So now we move on with an overview of pathological findings, and we discuss the appearance of blood at the level of joint. You know that when we examine blood vessels with ultrasound, the appearance of these vessels is completely black. This is an image of the carotid close to the bifurcation. We have a perfect detail of the walls, but the blood in itself is not enough to generate an echo. And so no echo is coded within a vessel. And we have potential reflectors within the vessels, and they are the red blood cells. But the red blood cells are smaller than the size of the ultrasound pulse. And when the reflector is smaller than the size of the length of the pulse, it is not able to generate an echo. This is the reason for which red blood cells within vessels are not able to produce echoes in the ultrasound image. And the reason is that red blood cells are smaller than the length of the ultrasound pulse. But in some instances, this is an example of a woman with some leg varices, Intravascular blood might occasionally appear echogenic. Look at these are varices, no? And when you give a look at these varices, you see something moving within them, no? And this is just blood. So by compressing with the vessels, with the probes, vessels are squeezed, and you can also see the swirling movement of red blood cells within this vessel. How is it possible to demonstrate blood in these vessels and not in the carotids? The reason is that in case the vessels have a very slow, stagnant flow, red blood cells forms piles, and the piles are longer than the length of the ultrasound pulse, so they can be identified on ultrasound, and an echo can be coded within the vessels. This is the physical reason for which in some instances we are able to demonstrate blood within the vessels with ultrasound. Just when red blood cells are close with each other, forming a pile. Remember, this is an important point. And this also may help us to explain why, at least in the early stages of a bleeding episode, in the first hours after a bleed, blood may appear homogeneously echogenic. And this is due to the fact that within the joint space, when we have a bleeding episode, the red blood cells form piles, no? And so when we compress, this is the suprapatellar recess of the knee joint, when we compress over this recess with the probe, we can see the echoes. You understand that this is nothing solid. We see just particles moving within the recess. There is no synovium. Everything is detached from the wall. So this means that in this case, the piles make blood echogenic at ultrasound. And so this is the typical observation of a fresh bleeding episode. After that, blood may clot, no? And when clots are relatively fresh, they look echogenic as well. So they appear as an echogenic solid tissue located within the recesses. It's interesting to note that with the time, far away from the bleeding episode, this kind of appearance is no longer appreciated. So blood becomes progressively dark. So it becomes darker and darker with time. And this is due to the progressive lysis of the red blood cells. Similarly, in cases of clots, clots are echogenic. Why? Because there is a mass formed by some aggregation of red blood cells. When the red blood cells start to dissolve as a result of a lysis, the reflectors becomes less intense, and so we are no longer able to demonstrate the clot as an echogenic structure. It becomes more a bit darker than expected. So in cases of a fresh hemorrhage, if you have any doubts about the correct interpretation of a recess effusion, of course, you can use dynamic maneuvers. You know that in cases of compression, we already saw an example, you can displace the piles of red blood cells, so you see the blood squeezed away from proper compression. But you can also use an old trick of radiologists before the advent of ultrasound, when in case of a suspected hemarthrosis, the patient was invited to lie down on the bed and not to move for 5-10 minutes to obtain the separation of serum from red blood cells. This could be visible, especially on ultrasound, is nicely visible because the serum remains hypoechoic and red blood cells forms a hyperechogenic level located in the most dependent part of the recess. So this is the position of the serum, and this is the position of the red blood cells. Of course, after looking at this kind of picture, you can invite the patient to flex and extend the joint, and you will see the red blood cells as they remix with the serum. This is another is a trick of the trade to be sure that what you are looking at is really related to a bleeding episode. So another thing ultrasound is able to disclose if is related to the question clinician may have about the fact that a bleed has stopped or not in the days after the episodes, no? And how to understand if the joint doesn't bleed longer. So if you rely on the progressive volume reduction of the joint cavity, remember that this is a very late process, no? It's very slow, and so it's difficult to perceive a difference, especially if you check the same joint after a couple of days. No, it's easy to perceive the difference if you scan the joint at the time 0 and after 2-3 weeks. But from day to day, this is not informative. But to understand if a bleed is ongoing, remember that the detection of echogenic moving blood, as we described it before, may be the key to understand if there is a continuing hemorrhage at the level of the joint recess. This is because the echogenic moving blood and the piles usually disappears after the acute episode. It takes some days, but at the end, the blood tends to become hypoechoic. And in case you, after some days, you continue to detect echogenic blood within the joint, this is a sign that may suggest that the bleed is ongoing at the level of the joint space. This is an example in which you see a joint with some thickening of the synovial membranes. In the joint, there were some clots, but after 1 week, 1 week after the acute event, we were also able to demonstrate that the fluid component was so echogenic, as you can see in this video clip. And this is absolutely abnormal after 1 week. And this may indicate that the blood, the bleeding episode has not stopped. So remember this point. Then, if you wish to have some criteria to distinguish synovium from clots generated by an acute bleeding episode, remember that synovium is a wall process. So anytime it's attached to the wall of the recess, you can see from some fronts the surface of synovium is irregular in general, and this is the typical appearance of synovitis. Note the other structure visible around at the level of this recess. This is the radial recess of the elbow joint. So the synovium is a diffuse process. The synovitis is a diffuse process. The synovium is invariably attached to the recess walls. It is characterized by irregular margin, by frondosities. In some cases, when it's too much, it may fill the recess completely, resembling a solid mass. And when we speak about synovium, remember that synovial hypertrophy is a dirty concept because it includes in its definition not just synovium, but also other things like hemosiderin, effusion, blood degradation products. So the concept of synovitis on ultrasound is really dirty. Most of what we see is actually related to synovium. But when we see an image like this one, probably we have synovium for the most, but part of the distinction is also related to other things like clots, blood degradation products, effusion, and so on. When we have just effusion, remember that effusion in general is related to a recent or acute bleeding episode. So, and based on detection of joint distension by synovium, we have a measure of the activity of the disease process at that level. Even if the patient is completely asymptomatic, even if there is no history of pain, of sudden onset of problems at the level of these joints, the detection of synovium in itself indicates activity of the disease process and probably some under treatment. And when we see a huge amount of synovium, as in this example, remember that you have to check the situation very carefully. You have to check the treatment plan to be sure that everything is fine. And anytime ultrasound can redirect your thinking, and it can help to take your attention to some problems in the correct use of prophylaxis or the treatment. But when the amount of synovium at the level of the joint spaces is less, anyway, the information is important for the clinicians, because even if synovium is not much, the presence of synovitis in itself may suggest a closer follow-up. Possible therapy change may be needed, or even when the joint is completely dry and we don't have any distension of the joint recess, this can be used as an important indicator that everything is fine at the level of that joint. But especially when we refer to some developing countries in which there are no resources for therapies, especially in cases of a patient with a lower risk of joint hemorrhages, ultrasound can guide a decrease in the level of the prophylaxis to use the drugs to direct the drugs, the high-cost drugs, to the patient who really need them due to a higher risk. So using ultrasound can provide some fine adjustment of the treatment in this patient. And regarding the way to distinguish blood from synovium, remember that different from synovial proliferation, blood clots are anytime detached from the walls. They are characterized by smooth margins and not by leaves, as you can see in this image. They recall the shape of the recess, as you can see here, and they are free of color signal cell Doppler imaging. So in some instances, things may be, of course, more difficult because there may be coexisting synovitis and blood clots in the same joint. Then everything may be easy when we are scanning patients with microbleeds in which some features of blood may help to understand if a bleeding episode has occurred at the joint level. And we see here some examples in which you see the signs described before. Remember that synovium in general is very homogeneous, and when you have a bleeding episode, the appearance of a recess is more heterogeneous. You can have some linear strands within the solid tissue, and this is not typical of synovium, but it may be encountered in cases of an hemorrhage. Then when we have a bleeding episode, we can also detect fibrins within the joint. Some problems may occur to identify minor bleeds or subclinical bleeds. And in this case, the diagnostic accuracy and confidence of ultrasound is less unless you go back and you have a baseline examination. If you have a baseline examination, you easily understand if there is an increase in the volume of the recess. And if the increase is clear and it has suddenly occurred, this means that a bleed has occurred at the level of the joint. On the other hand, if a pain is associated with a completely dry joint with collapsed recesses, this means that there is no bleed at all at the level of joint level. But anyway, detection of minor bleeds, especially in cases of coexisting synovitis, may be not so an easy task for ultrasound because we don't have a clear criteria unless the volume changes that can be appreciated suddenly after a bleeding episode to be considered. So, on the other hand, more experience is still needed to understand on how big should be a bleed to become symptomatic, on how big should a bleed to require a specific treatment. Remember that when we have a bleeding episodes, in general, the blood migrates within the joint cavity, but not uncommonly, blood may also affect the fat pads, because the synovium has no barrier at its base. So the position of the joint capsule is far away. We have the interposition of the fat pad. And so in general, we consider a bleeding episode something that can cause a distension of a joint space, but not uncommonly, we have the involvement of the fat pads. And so we have heterogeneous appearance of the fat pads. We see the synovium eroding the fat pads, invading the fat pads, as you can see in this example, and then signs of arthrofibrosis. So this is another example in which you see the synovium that has migrated far away from the expected level of synovium, invading the fat pads. And when we have arthrofibrosis as a result of a fibrotic response following repeated hemorrhagic episodes, you can also detect some images like this one, some black strands within the fat pad, like black flames, indicating the fibrotization of the soft tissues. So moving to the subchondral bone, remember that the ultrasound is not able to distinguish the different components of the articular cartilage. The articular cartilage appears as an homogeneous black tissue with no acoustic interface internally. So at the base of the cartilage, we have the subchondral bone, and the subchondral bone appears as a bright, smooth line. This is the typical appearance of the osteochondral surfaces in any of the joints. So this is the explanation for which the cartilage is not able to generate echoes, and this is due to the fact that it is characterized by relatively homogeneous components, and there is no change in density within the structure of the cartilage or change in the velocity of propagation of blood there. So this is a piece of bovine, a condyle of bovine, in which you see the cartilage, you see the medullary bone. This is a radiographic examination of this piece of the osteochondral surface, and this is the ultrasound appearance. So of course we are unable to depict the medullary bone with ultrasound because the beam is completely reflected at the level of the cortex. On the other hand, the cartilage is nicely imaged. And so based on these findings, even if ultrasound is not able to provide a comprehensive depiction of the cartilage across these surfaces, and this is due to the inability, to the lack of an access for the ultrasound beam to scan the most internal, the most central part of the joint. Ultrasound, when the joint surface is exposed, is able to disclose early changes affecting the cartilage and the subchondral bone, as you can see in this example of a partial thickness loss. And the resolution on this kind of damages is even higher than magnetic resonance imaging. The advantage of magnetic resonance imaging is related to the fact that the examination is very comprehensive. So MRI is able to depict the peripheral exposed part of the cartilage, and also at the same time the centrally located cartilage at the level of the white bearing surfaces. But remember that ultrasound is, even if it's able to demonstrate just a minor part of the osteochondral areas, it's really sensitive to disclose damage because the damage is diffuse. So it's mediated by iron, is mediated by the toxic action of the cytokines. And so this means that it affects the central blind parts, but also the peripheral parts. And looking at just the peripheral parts, ultrasound may have a better sensitivity than physical examination to understand if a damage is present. So look at these, compare these two images of the femoral trochlea, and you understand that in this case, the damage was more advanced with the full thickness losses of the cartilage here, and here is a partial thickness loss with a thinning of the articular cartilage. And in this image, you see the absence of the cartilage. You can recognize just bone and nothing more than bone. Of course, ultrasound can also demonstrate the deformity of the surfaces And these are the typical abnormalities observed at the level of the elbow, with irregularities in the shape of the capitellum. We may see some outgrowth of bone at the level of the radial head, and during pronation and supination movement, we can also demonstrate some instability of the joint. Posteriorly in the elbow, this is what happens in general. The irregularities in the bony surface of the trochlea are commonly found, and at the same time, the beak of the olecranon becomes longer and longer as a result of apposition of an osteophyte. In the knee, this is what happens with at the level of the upper pole of the patella and the trochlea, so the distance between the two bones becomes less, and you can see abnormal bony images. You see a step of deformity here at the trochlear level. When you place the probe at the level of the Parapatellar Recesses, not uncommonly, you can also see osteophytes on the sides of the two bone. And finally, what we described before, the osteophytes at the level of the medial aspect of the femoral tibial joint, with the osteophytes may appear very prominent here. The meniscus in this case is extruded, and if you look at this image, you also I understand that the joint width is much reduced. This is what happens at the level of the ankle. If this is the typical image of the dorsal aspect of the talus, with the dome, the neck, and the head, this is what happens in cases of advanced arthropathy. The tibia, which is typically characterized by downsloping contours, become very straight as a result of an osteophyte, and the osteophyte may become very long, very long. It is associated, typically associated with a counter osteophyte growing vertically at the level of the neck, and so these osteophytes may hinder the examination of the osteochondral surfaces of bone. But when we see this kind of picture, we can also assume that there is a profound damage at the level of the osteochondral surfaces in the wide-bearing areas of the joint. This is the ultrasound image of the two osteophytes. Of course, ultrasound is a dynamic examination, so you can also see the two osteophytes as they clash with each other. Very quickly, some notes about the scoring scale. The scoring scale involves the items related to disease activity and osteochondral damage, with decided not to score effusion, because effusion is a fluctuating parameter. And so regarding activity, we score Synovium in 3 grades: absent, minimal, mild, moderate, and severe. And so we do the same for cartilage and bone. The scale is an additive scale with range with values ranging from 0 to 8. And in case we have 0 for disease activity, 2 for cartilage damage, and a score of 1 for bone, we have to sum the items, and the final score will be 3. Then, even if the scale is additive, we can also decide to separate activity from the damage. And so when we use this scale, we can consider a subscore for activity and a subscore for damage. So in the elbow, regarding the score, synovial score, when the anterior recesses appears concave, and there is no communication between these recesses and the joint space, this is grade 0. Here is an example. We see minimal distension of the radial recess. The shape of the recess is concave. So the end of the recess is more or less here. This is the articular cartilage, and this is the level of the joint space. Similarly, if we see something bulging posteriorly at the level of the joint between the trochlea and the olecranon, but the protrusion of effusion and synovium is not such to reach the floor of the olecranon fossa, if you see just a limited image here, it's normal. So in case when the amount of synovium is much more and the anterior recess becomes convex, but the amount of synovium is not such to create a bridge over the osteochondral surfaces, it's grade 1. So it's moderate degree of distension. Similarly, when we see the synovium emerging from the joint line and pointing towards the recess, like what you see here in the schematic drawing, you see the synovium in blue sliding over the trochlea and then reaching the floor of the fossa, but not occupying more than 50% of the volume of the posterior fossa. We consider this degree of extension grade 1. So remember that the fossa, the posterior fossa of the elbow, is delimited by bony floors and by the roof, and the roof is considered to be the undersurface of the triceps muscle. So you consider this kind of area, and you have to evaluate the amount of synovium here. If its synovium is less than 50%, this means that it's grade 1, moderate. But when you have a big amount of synovium, and the synovium is able to open the space here over the distal humeral epiphysis, so to accumulate underneath the brachialis muscle, to distend the annular recess, and posteriorly to occupy more than 50% of the olecranon fossa, as you can see here, this is grade 2, that means severe involvement. So then how to score the elbow for synovium? We have to group the anterior recess in one, and of course we consider the posterior recess as a separate area. So if there is agreement between the score of each of the recesses, anterior and posterior, no problem, this will be the final score. But if there is a discrepancy, remember that the importance of the two recesses is more or less equivalent, and we'll select the highest value as the final score for synovium. So if we have 2 in the anterior recess and 1 in the posterior, the final score will be 2. Remember this point. Moving to the knee joint, until we see that the fluid or the synovium occupies the space in between the two fat pads, it reaches the tendon, the quadriceps, it touches the undersurface of the quadriceps, but is not enough to open the space here between the quadriceps and the prefemoral fat pad. This is absolutely normal. Similarly, if we see that some synovium exists at the level of the patellofemoral joint, but is not enough to be extruded out into the parapatellar recesses, this is normal. So this is an example of a normal amount of effusion. I see this image millions of times in normal population. And remember that this is the articular cartilage. The recess is located at the same level of the fat pads, but we don't have any recess located deep to the fat pads. So this is another example of an empty parapatellar recess. When the amount of synovium is more and is able to open the space between the quadriceps and the prefemoral fat pad in a cranial position relative to the prepatellar relative to the suprapatellar fat pad, this is abnormal. And if we are able to include the full image of the distension of the suprapatellar recess in one frame, in one image, is grade 1. So it means a moderate degree of distension. As you can see here, I see the synovium here opening the spacing between the two fat pads and then migrating more cranially between the quadriceps and the pre-femoral fat pad. And then I see that the amount of synovium hence here, this is grade 1. This is another example related to the parapatellar recesses, grade 1 again, because we have a distension that is less than 50% of the expected volume of these recesses. But when the synovium is much more, and we have a recess distension exceeding the size of the probe, and the probe is placed on the top of the patella. So you see that the image of the recess is cropped here. This means that is grade 2. It's severe distension of the suprapatellar recess. Similarly, in the parapatellar recesses, when you see that the amount of synovium is more than the 50% of the expected full volume of the parapatellar recess, is grade 2. But in different from the elbow, in the knee, the suprapatellar is much more important than the parapatellar ones. So when we score, we have to group the lateral and the medial recesses in one, and then in cases of agreement between the score of the suprapatellar and parapatellar spaces, there is no problem, of course. But when we have a disagreement, a discrepant finding, for instance, 1 in the suprapatellar and 2 in the parapatellar, remember that the suprapatellar is dominant. And so the score will be 1. And in other cases, if the score for the suprapatellar is 2 and parapatellar is 1, the final score will be 2, because the suprapatellar is much more important than the parapatellar. In the ankle, this when we have something at the level of the joint line anteriorly, or a pocket of synovium at the level of the neck, as you can see in this image, this is normal. And it's normal until the synovium doesn't cover the osteochondral surface of the dome and is not able to create a bridge between the joint line and the end of the neck. And similarly, if we see some synovium in between bones, but not bulging outside posteriorly, when we go to scan the posterior recesses of the tibiotalar and the subtalar joint, is normal. This is abnormal when we see that synovium is enough to create a bridge here, like in this case. This is an abnormal finding. And in cases of a moderate grade 1 distension, you can see mild concavity here, due to the fact that the pressure within the recess is not enough to press the fat pad towards the surface. This is 100% the distension of the anterior recess of the tibiotalar joint as assessed in cadavers. In grade 2, the amount of distension of the anterior recess is more than 50% of the expected volume of the recess in itself. And when we have distension posteriorly, we can see that the synovium tends to accumulate eccentrically relative to the joint line. So there is some distension of the recess for which most of the synovium is not aligned to the joint line, but it's located more inferiorly. In this case, the score is grade 2. So for the synostarsi, remember you have clear delineation, clear wall boundaries. The sinus is delimited by bone images. So if you close the space arbitrarily, you have to evaluate the amount of synovium within the confined space of the sinus. And so if a synovium is less than 50% of more than 50% of the expected volume of the space, you can decide about on how to score, if it's grade 1 or grade 2. So of course we don't make any difference between if the synovium belongs to the subtalar or to the talocalcaneonavicular joint. So in this case, we have to score two separate joints. So in regarding the tibiotalar, the anterior recess, remember, is dominant relative to the posterior one. And so when we have a discrepant finding at the level of the anterior recess, remember that between the anterior and the posterior recesses, remember that the score of the anterior recess will be the final score. In the subtalar joint, we have to group the subtalar and the talocalcaneonavicular joints in one. And again, for the subtalar joint, we have an anterior and a posterior recess. And if there is a discrepant finding, remember that the anterior recess of the subtalar joint is the dominant. So the score of the anterior recess will be the final score. And this is because the anterior recesses in the ankle joints are much easier to scan than the posterior ones. The posterior ones are very small. And so to make the process of scoring reliable, we decided to score just the anterior one in cases of discrepant findings. So I think I am at the end of my speech now. Of course, my speech was very dense because we described many things, many concepts, starting from the scanning technique. Then we moved to the depiction of the pathological findings ultrasound is able to disclose at the joint level. And finally, we gave an overview on the rules to score the different joints of the three joints of interest in hemophilia: the elbow, the knee, and the ankle. So thank you very much for your attention. I hope that my speech was productive for you and helped to clarify some issue. Thank you very much.
Thank you, Mr. Martinoli. Thank you for your really nice presentation, detailed presentation. Is there any question from the hall? Siz sorun, biz çevirmeye çalışırız. There is a question from the hall, Mr. Martolini. I will translate you.
Öncelikli sorum şu. İleri evrelerde, örneğin artık artrodeze gitmiş, artroplasti düşünülen olgularda örneğin bunu kullanabiliyor muyuz? Hangi hasta grubu, hemofili hastalığın hangi gruplarında bunu tedavi metodu olarak kullanabiliriz? Bunu ilk önce sormak istiyorum.
Sormaya çalıştığın şey şu mu? Yani ultrasonda ileri evrede bizim yani görmek, yani beklentimiz ne? Çünkü ileri evre görüntüleme yöntem, yani ileri evre bir hemofilik artropatide düz grafilerde biz çok detaylı bilgiler edinebiliyoruz. Evet. Onun için aslında bu kullanılan ultrasonun bir yeri yok. Yine de hani sormaya çalıştığınız şey tam buysa evet, ona göre. Bu. Peki. There is a question from the hall, Mr. Martinoli. One of our colleagues wanted to ask if we can do this scanning method for advanced stage hemophilic arthropathy. I already asked my colleague what did he want to ask. What do you think about that? Is there any place with ultrasound scanning for advanced osteoarthritis in hemophilic patients?
Yes, thank you for this question. This question is very important because, you know, ultrasound is a perfect tool when you have to scan early disease, no? Because in cases of early disease, it's able to identify some changes. And so based on the detection of these changes, you can do something, no, to stop the progression of the damage. Of course, when we have advanced arthropathy, radiography is still a very good examination to identify the status of bones. Not uncommonly in patients with advanced arthropathy, people may have a misleading idea of the occurrence of a bleed in the joints. When arthropathy is very advanced, in general, synovium is fibrotized, and we don't have any distension of the recesses. In patients who have pain, and they have doubts about the occurrence of a bleed or if pain is actually related to arthropathy, ultrasound may help a lot in these cases, just to say the patient, no, you don't have to treat yourself because it was not a bleed. The cause of pain was related to derangement of joints, so to a pure problem of arthropathy. Ultrasound may help in this patient to scan the other joints, not the end stage ones. No, the end stage ones is clear from the clinical point of view. If you wish to perform a radiographic examination, it's okay. You see what you expect to see. No. But not uncommonly, this patient may have problems in other joints that are not so end stage, no? And in these cases, if you screen this joint, you can identify some activity. And it's very important to preserve these other joints because they already have damaged joints, no? So in this case, ultrasound may have a role, not to scan the completely deranged joints, but just to complete the examination of the other ones to see if there is an activity of the disease process in joints that are not so bad.
Thank you.
Biz kalça ultrasonu bir defa yapıyoruz. Arada kaldığımız olgularda 1 ay sonra kontrol. Bunun sıklığı ne kadar olacak? Örneğin bir tarama yaptık. Klinisyen aktif mi değil mi öğrenmek istiyor. Belli bir süre sonra...
Kalça eklemi için bir kanama var.
Hani kalça için, hani ben kalça örnek olarak verdim. Biz bu hastalığın aktivitesini hastalardan nasıl ne kadar sıklıklarla bakacağız?
Yani klinik açıdan kanamanın devam edip etmediğine ne kadar sıklıkta bakmak.
Evet, yani klinisyen hangi durumlarda ben bir radyoloğum, klinisyenler hangi durumda bizden yardım talep edecek, biz hangi durumlarda bakacağız, ne kadar sık aralıklarla bakacağız, kanamanın hangi döneminden sonra veya hemartroz geliştikten hemen sonra mı yoksa belli bir süre sonra, bunun bir standardı var mı?
Yani ilk tanı koyduktan sonra tekrar ikinci görüntülemenin ne zaman yapılması gerektiğiyle ilgili. Yani bunu normal iyileşme periyodunun devam ettiği durumlar için söylüyorsunuz değil mi? Standart tedavi alan, faktör replasmanı yapılan.
Evet, evet.
Mr. Maltoni, our colleague, a radiologist, and wanted to ask another question. When he had a diagnosis with a joint hemorrhage due to hemophilia, when the standard treatment plan is with a standard treatment plan with factor and other painkillers and rest modifications, lifestyle modifications, when we should an ultrasound scan, At what time we will shoot another ultrasound scan to observe the joint?
So, of course, ultrasound is repeatable, no? So you can repeat the examination. There is no problem to do that. The point is that ultrasound may help you in the acute phase to aspirate blood from joints. And this is a new application. Probably it will become more popular in the future, no? To use ultrasound to remove as much blood as possible following an acute bleeding episode when the blood is not clotted yet, no? But if you wish to have an idea, if you wish to follow up an acute bleeding event, of course, you have to evaluate the joint, leaving some days in the interval. If not, it's difficult to understand which kind of change is occurring at the joint level. So my suggestion is time zero. If you wish to do something to inject or to aspirate blood, you can do at the moment the patient comes to your department. And then 1 week after, no? And so in 1 week, you are able to perceive what happens. So you need to leave some time. If not, it's very misleading because the estimation of the volume of the recess and the estimation of changes is really tricky because the appearance of the recess may change depending on the degree of flexion or extension of the joint. Different thing is when you use ultrasound as a screening modality. No, if you use as a screening modality, and this is a main role, you have to examine the 6th joint. Once a year is enough, I think. No, then you can collect some images. You can score the 6 joints, and if the patient has some news related to one specific joint, so there is a sudden onset of pain or an acute episode, you can go straight to examine that joint, So, but for screening, I think once a year should be enough. And it's if there is a treatment change, remember to examine the joints before you switch therapy and then after. This is also important to have an idea of the change.
Thank you, Mr. Martinoli. We thank your support, nice support to our Congress. We hope to see you in our next Congresses by face-to-face. Thank you very much. See you.
Thank you very much. I was really honored to participate, and I hope my speech, I think, was very complex, but I think this could contribute to solve some doubts about the use of this wonderful technique in the field of hemophilia. Thank you for your attention, and bye.
Thank you, bye. Oturumu kapatıyoruz. Teşekkür ederiz katıldığınız için.